Hello, welcome to Arcana Advances, where we discuss exciting new research in renal pathology performed by our own physicians. I'm Dr. Rebecca May, and today we have Dr. Chris Larson, who will be discussing one of his recent publications in Kidney International, titled Serum Amyloid P Deposition is a Sensitive and Specific Feature of Membranous-like glomerulopathy with masked IgG kappa deposits. Thanks so much for joining us today.
Yeah, happy to be here. Thank you.
First, can you describe membranous-like glomerulopathy with masked IgG kappa deposits? Quite a mouthful.
Yes, it's a terrible name.
Yes.
I hate the name, I'll be honest. I tried, backstory is when we first described this disease, I tried to name it as, I thought by saying how we would want to abbreviate it, and I tried to name it accordingly, and it ended up with the initials MMMG, and the idea was we were going to call it triple MG. Mm-hmm. And the reviewers of the publication didn't like the name, and this was the one they more or less suggested. And I regret now that I didn't fight more for triple MG, but this is what we ended up with. So hold on, you asked me to describe this disease, right?
Yes, yeah.
Membranous-like glomerulopathy with masked IgG kappa deposits. I'll start with the backstory. This was a disease that was discovered, or not discovered, I guess it was identified somewhat by accident. We had a biopsy from a children's hospital. It was a young girl who was 14 years old, and we looked at the biopsy, and it showed an enormous number of subepithelial deposits, very large subepithelial deposits. But the immunoglobulin staining was completely negative, so no IgG, no kappa, no lambda, nothing was positive. There was just some staining for C3, 1 to 2 plus staining for C3. So it was a little bit baffling because it otherwise looked like a membranous. I mean, I just felt like this has to be a case of membranous, but it's not. And so occasionally when a biopsy is performed, this is rare, but rarely in the suite where they take the biopsy, they may accidentally take that tissue that was intended for immunofluorescence and put it into the formalin. And when they do that, they render that tissue, it can't be used. I mean, even if you just dip it in the formalin, you can't use that for immunofluorescence anymore, for frozen immunofluorescence. So my first thought was, my fear is that somebody has this tissue has something's happened to it. It's just not useful for routine immunofluorescence. So I said, I'm going to repeat this on the paraffin. And I repeated it on the paraffin. I did the paraffin immunofluorescence, or some people will call that, the pronase digested tissue. It's more or less you take the formalin-fixed paraffin-embedded tissue and you perform a protease digestion step, and then you do perform the direct immunofluorescence. And when we did that, it was exactly what I thought would happen happened. I only stained it for IgG, interestingly. I didn't stain that one for kappa and lambda, but the IgG was 3 plus positive. And so I said, that's what happened. They've tampered, they've somehow, something's happened to the tissue that was submitted for frozen immunofluorescence, but we got to the answer. It's okay. We got there. And
Did you end up doing the kappa lambda?
I didn't done that one.
Okay.
So we have every day here, we have a conference at Arcana where we present interesting cases, interesting biopsies, new research studies, whatever. And I brought that case to conference and I said, hey guys, I saw this biopsy. This is what happened. And everybody was like, great job. You got to the answer. And so I was patting myself on the back. Well, about a month later, a colleague named Jane Bell, Dr. Jane Bell, came to me, and she came into my office in the middle of the day, and she said, I have another biopsy that's just like the one you showed us a month ago. It's a membranous, but it's only staining for C3. I don't understand this, but you know what? I bet they did the same thing. I'm going to stain mine with paraffin immunofluorescence. And she did the whole panel. And when she did, the IgG and the kappa were positive, and the lambda was negative. And we thought, well, isn't that strange? This young patient, and it's got this IgG kappa. But again, we just assumed somebody must have made a mistake with the tissue submitted for frozen immunofluorescence. And I did go back and stain my young patient for kappa and lambda, saw the same thing. And so we started to wonder, could this be something unusual happening here? Well, over the course of the next 6 months, 4 or 5 more biopsies came through the practice, exactly the same.
Wow.
Where they would be negative or very, very weak for IgG, and they'd have a little bit of C3 staining. But when you did the paraffin immunofluorescence, you would see the positive staining for IgG and kappa only. And so there a pattern emerged. The patients tended to be young. By that I mean 40 or less. The vast majority are 40 or under. They tended to be female. About, if I remember right, it's 70 to 80% of the patients are female. And it was common for them to have what we termed a vague autoimmune phenomenon. And so by that, I just mean they may have a positive ANA, but they don't have a diagnosis of lupus. I mean, dsDNA is negative, complements are normal. There's really no diagnosable autoimmune disease, but they do have some positive studies for lupus, like an ANA, or I remember one of the patients had ITP, you know. So that's kind of the backstory to how we. Anyway, we ended up seeing, enough of these patients. Eventually, we wrote a case series describing this entity. A few interesting things in addition to the demographics is that despite the fact that they are kappa restricted, despite the fact that they have light chain restriction on the biopsy, the patients don't have any detectable monoclonal immunoglobulin in the blood or in the urine, and they also, where was I going with that? They don't have any.
Yeah, so they don't have like a
I was going to say,
yeah.
So in addition to not having a detectable monoclonal immunoglobulin in the blood or urine, several of them underwent bone marrow biopsy, no evidence of any clonal population. So despite the fact that they have light chain restriction, we really don't believe this to be an MGRS.
Yeah. So thank you so much. That was such an interesting backstory.
That was a long answer to your question.
I really liked that because I didn't know how all of this really started.
Yeah.
How long ago was that you described that?
That, I don't remember. It's been a long time,
Several
Rebecca.
years, right? Yeah.
Lose track.
So this current paper, you were trying to find an antigen that is associated with this process. So you used mass spec of laser capture microdissected glomeruli. And can you just briefly talk about how that works? That technique?
Sure. This is a technique that is commonly used for typing amyloidosis. You can microdissect the amyloid deposits, and when you run the mass spec, you're able to detect the protein that's really the characteristic protein of the amyloid, or what's driving the amyloid deposition. So,
and this is selecting something that you expect to have positivity instead of scraping a whole slide with tubular interstitium and everything else. So here you went after the glomeruli where the deposits are.
In this, we were microdissecting the glomeruli. So from a biopsy, you may microdissect 10 to 20 glomeruli, and when you look at the sample after microdissection, just with the naked eye, it just looks like specks of dust. You can hardly even see it in the microfuge tube. But when we digest that and run the mass spec, believe it or not, from every one of those samples, you'll get 2,000 or 3,000 proteins are identified. So it's really quite amazing what can be done with mass spectrometry today. So really what we're doing here is we're looking for differential levels of a protein within a disease state versus controls. And usually we'll use disease control. So in this case, we would take cases of this disease, membranous-like glomerulopathy with masked IgG kappa deposits, and we would microdissect glomeruli from a group of those and compare with other types of membranous, membranous that's PLA2R, that's thrombosponden, other types of membranous.
And so, as sort of a proof of principle, you showed that the PLA2R cases
Right.
had a high fold change of PLA2R detected in them. And same for the other types where you knew the antigen.
That's right.
So your protocol was working. And then what did you find in the membranous-like glomerulopathy with masked
MGMID. We'll go MGMID. So,
what did you find in those cases?
Yeah, exactly. We wanted to make sure that that the technique worked for what we wanted, which was we were wanting to discover an antigen. I think everybody's kind of bought into this technology now. Dr. Sanjeev Sethi has really popularized the use of it for discovering proteins like exostocin and NEL1. This was before he'd published that work, so we still weren't sure. We felt like it was working well, but we wanted to prove that to ourselves. And so we became convinced it was very, very sensitive and specific for being able to identify the different types of known membranous cases. And so when we did this and compared the known membranous, the PLA2R, the THSD7A, with the MGMID cases, there were a few proteins that really were differentially present in the MGMID. And a couple of them you would expect, IgG and kappa. I mean, obviously you would have expected that. But in addition to that, you saw many proteins that seemed to be of the innate immune pathways, mostly complement type proteins. And then the most significant proteins, the one that had the highest level in the MGMID cases compared to the controls, had the highest p-value was SAP. I'm going, if you see my hands is at the top right, because that's in the plot where it was the most significant protein present. And it was first I saw that, and I just thought, that's curious, that I wonder what that means. And so I bought an antibody for SAP and stained these biopsies with the antibody and found that those deposits, we were seeing granular capillary loop staining in these cases, exactly like what we were seeing for the IgG and kappa. So obviously, that's when it really became interesting. Like, okay, this SAP, it seems to be uniquely present in the deposits in this type of glomerulonephritis. The PLA2R, the thrombosponden, I'd stained those. The deposits did not stain. So there was SAP present in those, not just in the glomeruli, but specifically in the deposits in the glomeruli.
And that's also really important, right? Because we're not going to be able to do mass spec routinely, at least at this point, on every membranous case.
Right.
So,
it's a useful biomarker for the disease.
It's much easier for us to do an IHC and see that come
up.
Exactly.
This is a disease that, you have to have some index of suspicion in order to even... we don't routinely perform paraffin immunofluorescence on biopsies. You only do it if you only perform that analysis if you think that it might add something. And so you have to take that next step from your routine immunofluorescence. And so I think that it provides a level of confirmation that we're dealing with a specific disease entity. So in these patients that have MGMID, uniformly 100% those deposits will stain positive. But in patients with other types of membranous, they're negative. So we find it useful just clinically in a routine clinical pathology practice for the diagnosis of this entity. Now, our real hope was that this could tell us something about the underlying pathogenesis of the disease. I still believe that it does, but at this point in time, I really can't tell you exactly what that means. We could never definitively show that these patients have autoantibodies directed against SAP. So I mean by Western blot or ELISA. So what it exactly. It may not. That doesn't mean they don't. It's just that we couldn't show it in vitro. We could not show that. So also why the patients have kappa restriction in the deposit. Still, I'm not confident that this really gives us any answers as to why that is the case. It does tell us a little more about the disease, though.
And you went on to test SAP antibody staining on a large cohort of cases.
Right, yep.
You picked a lot of different cases, a whole wide range of cases. And basically, it was positive in all the cases with these masked deposits. They were all IgG kappa restricted. It was negative in another sort of masked disease that we see, cryo. And other membranous cases. It stained in amyloid, as you might expect, because it is present in amyloid. But it also detected something interesting, that it detected some membranous cases that didn't mask.
That's true. That's true. Yeah, that was one of the interesting findings. We did have a group of patients that had glomerulonephritis that was a membranous pattern, and they stained for IgG1 kappa.
Yeah.
IgG1 kappa. But they were not masked. They stained on the routine immunofluorescence for that. So, interestingly, the only group that SAP was positive in, aside from the truly kind of masked MGMID, were these biopsies of membranous that had IgG1 kappa. And so I do more or less that I think what that informed was that there is a subset of MGMID that does not mask for whatever reason. And, we don't even know exactly why. That's usually a question people ask when they learn about this disease. Why doesn't it stain on the routine immunofluorescence? And the answer is, I don't know, But it doesn't. We just know that it doesn't. But in a subset of cases, the IgG1 kappa can be detected by routine immunofluorescence, and that probably is the same disease as the masked ones, because they also have SAP in the deposit. The IgG2, the IgG3, the IgG4 kappa, no staining for SAP. Only IgG1. If membranous, if it was a monotypic membranous with IgG1 kappa, not all the time, on just routine immunofluorescence, not all the time, but some of the time, those would stain positive for SAP.
Yeah, so it's important to do that in clinical practice when you see that come up, to do that stain.
I think so. If you have if you have a case that even by routine IF stains positive for IgG1 kappa, I think it's worthwhile to do the SAP.
And what do we know about the function of SAP at this point?
Yeah, we know surprisingly little about this protein. I mean, it's named for what we know best about it, serum amyloid P. It's ubiquitous in amyloid deposits. It's always present. Regardless of the type of amyloid, SAP is going to be present. But what it's actually doing, it's evolutionarily conserved in all invertebrates. So it's clearly important. It has a lot of homology with C-reactive protein, an acute phase reactant. There is data to show that it is involved in the innate immune system, probably is important in that. There are mouse models in which an SAP deficiency results in an autoimmune kind of lupus-like disease, including glomerulonephritis. So it definitely seems to be important in the innate immune system, but really exactly how or why is still a mystery. It's amazing how much we still have to learn. When you really start learning about things like this, and you may have talked about serum amyloid P your whole life, or your whole pathology life with regards to amyloid, but you start looking at what this is, and you realize we have no idea. We really don't know what this protein is present in humans for. It's present at quite high levels, but yet we don't know why. So
much left to discover, right?
That's for sure, yeah.
And does this provide any insight for therapy for these patients? How do they normally do?
Yeah, so in the last case series, we had 2 case series. One was a smaller one where we initially just described the disease, and then a little bit larger one that also included some follow-up data and treatment data. And it was all over the map, to be quite honest. I mean, in some ways it was similar to what you see in membranous. I mean, there were patients that would progress to end-stage kidney disease. Then they'd have a transplant, and they'd have recurrence in the transplant. There were other patients that would just spontaneously remit, no treatment whatsoever. And unfortunately, there did not seem to be really a correlation between any specific treatment and the outcome. And that's unfortunate because when people look at the paper, or these are emails that I feel quite frequently, how should I treat this patient? The answer is still, I don't know. You know, there's not any good evidence-based therapy at this point in time for this disease. It does seem to be, the hypothesis is that there's some autoimmune etiology probably to this. It seems reasonable to me to have the patient on some form of immunosuppression, but exactly what regimen that is or what that should look like, we just don't know.
Yeah. Well, thank you so much for joining us today and telling us about this interesting disease process.
Yeah, thank you for having me.
Really wonderful. And you can follow us on Twitter at Arcana Labs. And do you want to share your Twitter handle?
It is RenalPathDoc.
Great. Well, thank you so much.